Hi again everyone, and welcome to the second of my series of videos about labour and delivery, in which I'm hoping to deliver some of the information that I would normally give in the rooms so that we can limit the amount of time we're spending face to face during the coronavirus pandemic. My intention is that you'll absorb this information ahead of time and then we have a more focused discussion on the day. I have designed these videos to be watched in order, so if you haven't watched the first one, I'd suggest that you do that first. What I wanted to talk about in this video is our two big interventions in labour, the caesareans and the instrumental deliveries. Not because I think that these are particularly likely to happen to you, but if they do, I think understanding how they work, the reasons why we do them, just makes them a little bit less daunting if they happen on the day. Remember, labour is unpredictable, and as I was saying in the first video, as well as keeping you safe and the baby safe, I want you to feel like it's a good experience regardless of the way it pans out. And I think understanding the reasons why we make some of the decisions we do, or the reasons why I might make some of the recommendations that I may make, helps with that process. So caesareans first. About 20% of women in labour for the first time will need a caesarean. That number is much lower for women having their second or third baby if they've had a previous vaginal delivery. There are lots of reasons that people need caesareans before labour, of course, but once you're in labour, the rate is about 20% for a first timer. And that's pretty consistent when you look at data from lots of different places and lots of different sources. Unfortunately, we're not very good at picking that 20%. If we were, we wouldn't make those women labour, we would just do caesareans for them so that they have only one thing to recover from. But because you've got an 80% chance of a vaginal delivery, unless you don't want to, we tend to think that it's worth a try. There are sometimes some women that we can identify ahead of time as having a much higher risk of caesarean section, and if I think that you're in that category, then of course I will discuss that with you. The first reason we do caesareans in labour is if the baby's just too big to fit out, and what you get in that setting is an obstructed labour where you keep contracting but the cervix stops dilating, and there are a whole lot of other signs that go along with that. It's a purely mechanical problem, and as I'm sure you can understand, there's really only one solution that allows a good outcome. Sometimes the diagnosis is obvious, you have all the signs of an obstructed labour, but it's often something that develops over several hours. Every time I examine you, I'll tell you what I think's happening. If I'm worried that the progress is starting to slow down and we might be looking at the early stages of an obstructed labour, then I'll certainly tell you that. But sometimes it's not entirely clear, and it is something that evolves over time. So if we're not entirely sure that that's what's going on and you're okay and the baby's okay, together we might decide to continue the labour and let the situation declare itself. The other reason that we do caesareans in labour is if the baby doesn't tolerate the hard work of labour. We spend a lot of time thinking about how hard it is for the mothers and talking about how hard it is for the mothers, but it's hard work for the baby as well. And the baby's relying on the placenta to give it everything it needs to get through the hard work of labour. Generally speaking, a healthy, well-grown baby and a healthy, well-functioning placenta will do very well in labour. But you'll notice in the labour that what we're looking at is the way the baby, when we're monitoring the baby, what we're looking at is the way that the baby's heart rate responds to a contraction. We are expecting a response. The baby is exercising and will have a normal and healthy response to stress and exercise, just like you will be having. But we can tell the difference between that normal and healthy response to stress and exercise and a baby that's starting to run out of steam, or a baby that's really running into trouble. And particularly if we're not near the end and that's happening, then usually a caesarean is the best situation. Again, it's often something that develops over time. Babies are very resilient, and usually once we've delivered them by caesarean and they're out in the outside world and we've removed that stress, they usually recover very quickly. But if they don't, for whatever reason, at least we've then got the baby in the outside world and can do whatever we need to look after it. Although we call these caesareans emergencies, it doesn't mean that it's a drop everything race to theatre emergency. For someone who works in a hospital, the difference between an emergency and an elective procedure is just that an elective we've planned ahead of time and an emergency we're organising on the hop. So it's actually very uncommon that we need to do anything so quickly that it's drop everything, rush to theatre. And there's usually plenty of time to talk about what's happening, and together we'll make the best decision for your situation. The other big intervention we have are the instrumental deliveries, so the forceps and the ventouse, or the vacuum cup delivery, and the rationales for those are kind of similar to the caesareans. The second stage of the labour, the pushing bit, is the hardest bit for you and the hardest bit for the baby. And sometimes the baby that's cruised through the first stage of the labour, the dilating phase, will start showing some signs that it's running into trouble in that second stage. Most of the time for your first baby, it takes about an hour to push the baby out, an hour of fairly solid hard work. You'll be pleased to know that second and subsequent babies are usually much quicker. Some women, even in their first delivery, can get through the second stage much more quickly than that, which is fantastic. Some take a little bit longer, but an hour is a reasonable ballpark average, and an hour is obviously a long time to leave a baby if it's in trouble. With the forceps or the ventouse, and you and I working together, we can turn that hour into about 5 minutes, which, like for the emergency caesareans, then the baby's in the outside world and usually recovers very quickly, but if not, we can do whatever we need to do to look after it. We are working together with the instrumental deliveries, and it still does require a fair bit of effort from the mother. It's not a free ride for you, but it does speed up the process considerably. The other reason that we do instrumental deliveries is if you're not able to push the baby out under your own steam, and there are lots of reasons for that. At the end of the day, it is just a very hard thing to do. It's probably physically the hardest thing you'll ever do, unless you take up some sort of crazy extreme sport, and then probably even then this is the hardest thing you'll ever do. Size matters, of course. The bigger the baby, the bigger the head, the tighter the fit, the harder it's going to be to push the baby out. And the position that the head gets itself into in labour, which despite what you read is not something you have a whole lot of control over, can make it harder or easier for you. If you've had a long labour and you're exhausted, then that obviously is going to make it harder to summon the strength to push the baby out. And for those women, I think they're best advised to have some pain relief so that they can get a bit of a chance to rest and get their strength up for that part. But it is the one downside really of an epidural, is it can make it harder to push. It doesn't always, in fact it doesn't usually. As I spoke about in the first video, what we're trying to do for women who choose to have epidurals is we're trying to take away their pain without taking away too much other sensation, and hopefully they can still move and coordinate everything and have enough sensation to push. But the more you can feel, the easier it is to push. There's no doubt about that, with the downside being, of course, that it hurts more. We have lots of tricks and tips we use to get people pushing in the right place, even if they can't feel anything. And plenty of people with epidurals push really well. And having an epidural doesn't mean you won't be able to push out the baby. And similarly, not having an epidural doesn't mean that you will be able to push out the baby, because all those other things like size and position and exhaustion factor into it. So I think it's worth knowing that epidurals can affect pushing, but having an epidural doesn't mean you won't be able to push. So I think you decide, like with any pain relief, you decide on the day whether or not to have one, depending on how you're going and how you're feeling. People often ask me about the difference between the forceps and the ventouse and whether I have a preference. I don't really have a preference, or I guess I have a preference that you use the instrument that's appropriate for the situation. There are some babies that can only be delivered safely with the vacuum and some that can only be delivered safely with the forceps. Remember that I've done this a lot and I've been doing it for a long time, and you can trust me to make the appropriate choice on the day if you do need an instrumental delivery. So that's it. That's our two big interventions in a nutshell. When you lay them out that quickly, it does make it sound, I think, a little easier than perhaps it actually is. But caesareans, because either the baby doesn't fit or the baby doesn't tolerate the hard work of labour, and the instrumental deliveries, either because we need to speed up the delivery because the baby's running out of steam, or you're not able to push the baby out for all those reasons that we discussed. Have a think about all of that, see if it makes sense, ask me lots of questions when I see you in the rooms, and in the meantime, take care.